Hi friends, from today onward I will be starting the new series on cardiovascular system. In this video I will talk about proper format for history taking and general examination. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. This is the case sheet format for taking the proper history in a case of cardiovascular system involvement. In history taking, we will write down his name, age, sex, residence, occupation, chief complaints. Chief complaints are described in chronological orders in the numbering 1, 2, 3. And the symptomatology, like if there is patient presents with dyspnea, its duration, onset, grade, progression, aggravating factor, relieving factor, whether there is any history of orthopnea, Trepopnea, Platypnea, Bendopnea, whether there is any history of paroxysmal nocturnal dyspnea, or any other associated symptom like wheeze, cough with expectoration. If patient comes with the chest pain, duration of the chest pain, how was its onset, site, type of the pain or character of the pain, its radiation, whether there is any diurnal variation or not, aggravating factor, relieving factor, associated symptoms like nausea, vomiting, sweating, dyspepsia, whether there is any local tenderness, whether there are any anginal equivalents or there are not. Anginal equivalents are dyspnea, diaphoresis, discomfort in lower jaw, dyspeptic symptoms, fatigue. If the patient comes with palpitation, duration of the palpitation, how was the onset, whether it is a fast palpitation or slow palpitation, whether it is regular, irregular, what are the precipitating factors, what are the associated symptoms, is there any history of Stoke Adams, is there any post palpitation diuresis. If the patient comes with history of syncope, how was the onset, what is the duration, how many attacks has happened till date, whether when he gets the attack of syncope, does he have awareness about that or not, what are the precipitating factor, what is the associated symptoms, if the patients have pedal edema, duration, onset, progression, what are the aggravating factor, relieving factor, is the pedal edema preceded by facial puffiness or followed by the facial puffiness, other symptoms like any history of hemoptysis, cyanosis, decreased urine output, gastrointestinal symptoms, right hypochondrial pain, fatigability, fever, rheumatic fever history, whether any history of infective endocarditis, cyanotic spells, sweating after exertion. In the past history, we have to ask him about asthma, chronic obstructive airway disease, any history of tuberculosis, history of contact with the tuberculosis patient, any history of diabetes, hypertension, ischemic heart disease, seizure disorder, history of sudden cardiac death, family history. We have to draw 3 generation pedigree. This chart has to be drawn. Whether there is in the personal history, we will ask him about bowel habits, bladder habits, how is it his appetite, whether he has any history of loss of weight, occupational exposure, how is the sleep, dietary habits, and other taboos, history of any food allergy. We have to ask him about the smoking history, how many packs of cigarettes he consumes, alcohol, how many grams he consumes the alcohol, whether there is any history of treatment, if he is taking some drugs, what are the drugs, what is the frequency of drugs, whether it is taken daily alternate day or 5 times a day, duration of the dosage, any blood test he has undergone so far or undergoing regularly. For example, if the patient is on warfarin, he periodically checks his INR, any history of intramuscular injections once in a 3 weeks. That is most likely penicillin for rheumatic heart disease patients. Given for prophylaxis in female patients, we have to ask we have to ask her about menstrual and obstetric history. What is the gravita parity? How many live births are there? Is there any history of abortion? What was the age of menarche? Does she has achieved menopause? If yes, what was the age and duration? After taking proper history, we have to summarize the history and make the differential diagnosis, at least three differential diagnoses. In general examination, we will see whether the patient is conscious, coherent, cooperative, obeying commands or not. We will check his body mass index. Body mass index is weight in kg per meter square, and we have to grade that BMI according to WHO for Southeastern Asian countries. We have to check his arm span. We have to check his upper segment, lower segment ratio. We have to do vital examination by like pulse rate, rhythm, volume, in volume character of the pulse, vessel wall thickening, whether there is any radial delay or radiofemoral delay. We have to check all the peripheral pulses. Blood pressure has to be checked in the right arm, right leg, left leg, whether there is any postural drop in BP. We have to check the respiratory rate, whether it is regular, irregular, what is the pattern, abdominothoracic or thoracoabdominal. Thoracoabdominal is more common in female and abdominothoracic is seen in males. Whether there is any use of accessory muscles when the patient is breathing. We have to check for JVP and mention it as dash centimeter of water or blood above the sternal angle. We have to check for any venous pulsation. We have to check SpO2 through pulse oximetry. In physical examination, we will check pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema, other like signs of any infective endocarditis or any other signs of rheumatic fever. After doing general physical examination, we will do the inspection. We have to check for the chest shape and symmetry, whether there is any breast abnormalities, any spine deformities, whether there is any precordial prominence, cardiovascular pulsation, apical pulsation, pulsation in the aortic and pulmonary area, sternoclavicular pulsation, left parasternal pulsation, epigastric pulsation, ectopic pulsation, whether there are any distended veins or not. After inspection, we have to confirm the confirm the findings of the inspection by palpation. We have to confirm the shape and symmetry, palpation of the precordium, palpation of the cardiovascular pulsation for sounds, thrills, and rubs. We have to check for tracheal tug sign. After palpation, we have to do the percussion. We have to percuss the right border of the heart, left border of the heart. We have to percuss in the second intercostal space. We have to percuss the sternum. In auscultation, we will check the apex, tricuspid area, herbs, neos, aortic area. In the apical area, the mitral area, we will check for S1, S2 heart sound, whether there are any S3, S4 sounds, whether there is any opening snaps or clicks, if there are any murmur, what is the timing, what is the grade, quality, pitch, configuration, whether there is any radiation of the murmur, whether it is best heard with the diaphragm or the bell, what is the position of the patient when it is best heard, with breath held in inspiration or expiration. We have to do the dynamic auscultation also. In the tricuspid area, we will check for heart sound S1, S2, S3, S4, whether there is any opening slaps or clicks, if there is murmur, the timing, grade, quality, pitch, configuration, radiation, whether it is best heard with the diaphragm or the bell, patient position. We have to check it with patient's breath held in inspiration or expiration. We have to do dynamic auscultation. In herbs neotic area, we have to check for heart sound S1, S2, S3, S4, opening snap, clicks, murmur, same timing, grade, quality, pitch, configuration, radiation, best heard with the diaphragm or the bell, patient position with breath held in inspiration or expiration, dynamic auscultation. In the right second intercostal space, that is aortic area, we have to check for S1, S2, S3, S4, opening snaps, clicks, murmur, timing, grade, quality, pitch, configuration, radiation, best heard with the diaphragm or the bell, patient position with breath held in inspiration or expiration, dynamic auscultation. Similarly, in the left second intercostal space, that is the pulmonary area, we will check all these things. The heart sound S1, S2, S3, S4, opening snap or click, murmur, timing, grade, quality, pitch, configuration, radiation, best heard with the diaphragm or the bell, patient's position with breath held in inspiration or expiration. We have to do the dynamic auscultation. Besides auscultating all these areas, other areas which are also auscultated are axilla, the epigastric region, clavicle, carotids, and the back, especially the interscapular areas. After doing this, all this cardiovascular system examination, we have to uh, do the respiratory, gastrointestinal, and nervous system examination also. In respiratory inspection, we will do inspection, palpation, percussion, auscultation. Similar is for the gastrointestinal inspection, palpation, percussion, and auscultation. For nervous system examination, we will do higher mental status function, cranial nerve examination, sensory system examination, motor system examination. We have to check for the reflexes, cerebellar sign, and meningeal signs. Dr. Christine Northrup has said, "Your body is your best guide. It is quietly demands. It quietly demands that you make changes in your life." Dr. Christine Northrup has said, "Your body is your best guide. It quietly demands that you make changes in your life." With this, I conclude my today's topic. Thank you. Keep learning.